Hi, I'm Dr. Jeremy Smith. I'm an orthopedic spine surgeon at Hoag Orthopedic Institute. I'm very happy to be virtually presenting one of my favorite topics to you today. I'm going to be presenting today some minimally invasive options for spine pathologies or afflictions. I'll go over a few of the pathologies, some of the basic ones that I most commonly see in my office, and we'll go over some of the minimally invasive options that we have now currently. And certainly along the way, I'm happy to answer questions if you want to relay them. I'll try to answer them during the talk, or there'll be some question time reserved at the end. So first off, a lot of the questions I get from a patient coming in to see a spine surgeon is, well, who do I see, an orthopedic surgeon? Do I see a neurosurgeon? We'll answer those questions for you as how to pick an orthopedic versus neurosurgeon. What are the common spine pathologies? And the most common ones we see we'll present, and then these minimally invasive options, both in the lumbar spine as well as the cervical spine. So with regards to a spine surgeon, neurosurgery versus orthopedic surgery, it's kind of the age-old questions. If we look at the traditional thoughts, the neurosurgeon treats the nerve and the orthopedic surgeon treats the bones. In fact, there would often be both in surgeries in the past, where the orthopedic surgeon would put in screws and rods and fixation, and the neurosurgeon would do a decompression and take care of the spinal cord or nerves. Now it's different. Now most spine surgeons have dedicated fellowship training in spine. So it doesn't matter whether you have an orthopedic surgeon or a neurosurgeon, as long as they have dedicated spine training and often a year of dedicated spine fellowship. That's an important quality for your spine surgeon to have. So it's a common question that comes up, and a question that you can ask your spine surgeon is how much spine surgery do they do in their normal practice, and did they have dedicated spine training? So I'm commonly asked, and have training with neurosurgeons as well as dedicated orthopedic fellowship. It's something even today we cross boundaries and work with the neurosurgeons quite commonly. So, but the key part is that your surgeon has dedicated training in spine. So minimally invasive surgery, it's really performed for both minor and major pathologies. There's minimal soft tissue disruption, smaller incision, less blood loss, and shorter hospital stay. The traditional means of spine surgery is a large open surgery. Commonly hip graft would be taken. The surgeries are quite morbid and would require a significant amount of time to recover from surgery. So these options now really for almost every pathology exist and make a recovery much easier. We have to be careful and look at the specific pathology. Not everyone qualifies for these minimally invasive options, but certainly it's worth broaching the subject with your spine surgeon if you have a condition that requires surgical treatment. So this is just an example of the size of the incision. The common diagnosis that we're going to go over today is sciatica, is a very common diagnosis, a lumbar stenosis, cervical arthritis, and some of the conditions that are associated, and scoliosis. So sciatica, one of the most common presenting conditions that we see, often with pain, numbness and tingling and weakness, and typically down the extremity. Usually it's in a pattern what we describe as a dermatome. It really means that sensory pattern of the nerve. For instance, we commonly think of sciatica as being the S1 pattern, which is the buttock, back of the thigh, into the back of the calf, into the foot. L5 is a little different. It's on the outside of the thigh to the outside of the calf and into the top of the foot. Commonly when we think of sciatica, it's really a pinched nerve. And it's often caused by a disc herniation. It usually presents very suddenly. Sometimes patients say, I really wasn't doing anything. I turned to the side, I coughed, and it was something very little that causes the symptoms to occur. Patients commonly cannot sit. I'll often walk into the office and the patient will be standing, walking around, unable to sit. They can often lay, but it's very difficult to sit. If it affects the right lower extremity, it's often very difficult to drive. Patients commonly present from the ages of 20 to 40 years old. We see the diagnostic tools that we use are the X-ray and MRI scan is kind of the gold standard to see if there is a herniated disc. It can be also caused by some other pathologies, but the herniated disc is the most common one. We can often, it's most common to occur in the L4-5 or the L5-S1 region. It's something in its most severe form. It can cause bladder or bowel incontinence or severe weakness, and that can actually be a surgical emergency. So those situations are ones that require a trip to the emergency room as soon as possible. So the run-of-the-mill sciatica commonly heals 75% of the time without surgery, and the conservative treatment strategies include a combination of anti-inflammatory medications, sometimes in the acute period a course of steroids, plus or minus epidural steroid injections and physical therapy. Really, that time period of about 3 months is 75% of the time it will really go away on its own. Your body is remarkably able to heal itself, and even in the setting of a very large disc herniation, barring there isn't a significant neurologic deficit or something that indicates surgery sooner than later, we'll often wait and try some of these conservative measures. So when it comes time to surgery, we consider a microsurgery. This is kind of the gold standard for minimally invasive surgery. So a microdecompression or microdiscectomy. It's often done through an inch or 2-inch incision. The nice part about this is we can spread the muscles. We often don't have to cut the muscles, such as the traditional open approach. I see sometimes patients come in who have had microdiscectomies and say in the 80s or 90s, and then their incision is quite large. Really, the incision for a single level microdiscectomy only has to be 1 inch or 2 inches. There is a tubular system where we can actually distract the muscle without damaging it directly. What really makes the surgery more damaging is when we have to spread the muscle off of the bone. When we do that, it never is quite the same. It actually denervates, and so recovery becomes difficult, and it's something that does require a longer period of recovery. So this is a view on the left side is the X-ray, really showing the site intraoperatively, and you can see our vision of field, and so we are able to access and really see and remove those disc herniations quite precisely. So the picture on the left is actually a disc fragment, a very large disc fragment that was removed and was herniated. And some question, how large a lumbar spur protrusion is significant? So great question. You often read your MRI report, and it isn't so much the size that matters. It really is actually how much room there is. So some patients have very wide spinal canals, and it can accommodate, say, a 4, 5, 6, or 7 millimeter disc bulge or herniation. But it's really, if there's not much room there within the spinal canal, unfortunately, it becomes more of a problem. So oftentimes patients with even 2 or 3 millimeter disc herniations have very little area in their spinal canal, might be very symptomatic. So it's not so much how big the disc is just how much space is it taking up and how much the nerve is being pressed. Just to move on a little bit, this shows us again the pros of doing the microdiscectomy or doing the minimally invasive approaches. This image on the right shows kind of the digital dissection that we do between the muscle groups. So it's not denervating the muscles, we're maintaining that nerve supply. So we try to maintain the integrity of that muscle. So smaller incision, again, the studies show there's often reduced pain, less narcotic requirement, and certainly an earlier return to function. Some other questions, sorry. Endoscopic surgery is a topic that I'll briefly go over. It's kind of a more up and coming, it's becoming more commonplace, and I get a lot of questions regarding endoscopic surgery. It's one that really takes of a specific diagnosis in pathology, and really not all patients are candidates for it. The pressure has to be in a specific region and has to be accessible through the endoscopic system. So it's done in situations when there's more bone spurs and disc fragments outside of the spinal canal that are difficult to approach through traditional, minimally invasive means through a midline approach. It does require a significant amount of training on the part of the surgeon. You want to make sure that you have a surgeon that really focuses a large portion of their practice on endoscopic. Unfortunately, I've seen a lot of injuries being caused by it. My personal opinion is that the endoscopic spine surgery is relatively in its infancy, but it has hope to really be more of a mainstream method. It is becoming that, but still has to be seen as it's an option in certain conditions. Your pathology has to fit the criteria that would be taken care of by endoscopic spine surgery. And in these situations, I always recommend getting a few opinions regarding the appropriate treatment strategy. So lumbar stenosis is a little different than sciatica. Essentially, stenosis is if there's narrowing of the spinal canal. So if we're simply looking at the area for your spinal nerve roots or your spinal cord, if there's less room, that's what stenosis is. So stenosis is generally caused by a compilation of pathologies in the lumbar spine. It could be caused specifically by the joints becoming arthritic and enlarged. It can be caused partially by the discs herniating. It's caused by bone spurs. Oftentimes the disc, if it's sitting there, it's herniated for a period of time, it can become calcified. It can be caused if there's a malalignment problem, something called a spondylolisthesis. And that's essentially if there's a shift of the vertebra, and that's often caused by instability. It's caused by an arthritic process. The symptoms are a little bit different than what a sciatica presentation is. It's similar in the regards to it can affect your leg, buttock, can cause some numbness. Generally, it causes a heaviness or fatigue type of symptom that's worse when you're standing upright and walking. So as opposed to sciatica, where it's very difficult to sit, it's very, when you sit with stenosis, it actually relieves the symptoms. One common question I ask is that if you're at the grocery store, does it feel better if you're leaning forward? It's really important to understand that, and it does contribute to how we treat patients. So again, you know, it's a similar concept, and the nerve is being pressed and there's less room, but it's a different symptom and a different, certainly a different treatment strategy. So again, this is a schematic of what stenosis looks like. On the left, you can see very arthritic joints causing a pincer effect on the nerves inside the dura. The dura is the outside covering of the nerves with spinal fluid. On the right, we can see an MRI scan. That's a view of an MRI scan where we see discs that are bulged, as well as arthritic joints, and that's narrowing the area for the nerve roots. We can actually see segmentally that there's stenosis at 3 levels there that looks quite severe. Some of the common causes, degenerative disc disease, which is really a compilation of disc herniation, disc bulge, disc height collapse. A spondylolisthesis is a fancy term for saying the vertebra is shifted. It doesn't align with the vertebra above or below. And a cyst, just like we hear about a Baker's cyst in the knee, a cyst can happen in the joints in the spine as well. As those joints become arthritic, the soft tissue capsule becomes irritated by bone spurs and can actually create an outpouching cyst that oftentimes just goes into the soft tissues surrounding and may not have an effect, but unfortunately can press on the nerves within the spinal canal. So all of these can cause stenosis. Conservative strategies, the success rates depend on the severity of the stenosis. So patients with severe stenosis, unfortunately, it's a mechanical phenomenon where the blood flow is limited. Unfortunately, the success rates of conservative strategies that we discussed before that were very good for sciatica aren't as successful for stenosis. We still try them. We still try to adjust your activity level, work with your core muscle strength and physical therapy, try anti-inflammatory medications and epidural steroid injections, but the success rate, unfortunately, is difficult. I'm getting a question here. Are there any preventative measures that can slow the progression of a spondylolisthesis? So great question. Spondylolisthesis, there's really two main types. There's one, the degenerative type caused by arthritis that we're talking about, and there is what's called an isthmic type. An isthmic type is caused by a fracture. The best way in either types of spondylolisthesis is an attention to your core muscle strength and posture. It really is about controlling your motions, engaging your core muscle groups with your spinal motions. There isn't an injection, unfortunately. There isn't a specific treatment strategy that can overwhelmingly prevent spondylolisthesis from progressing. That being said, degenerative spondylolisthesis are less likely to progress. We grade them 1 through 4, and the most common degenerative spondylolisthesis is a grade 1, and rarely does it get to a grade 2. A isthmic or spondylolisthesis, or spondylolisthesis caused by a fracture, can actually progress. It's more likely to progress. So if I see a patient, and they're generally a little younger, who has a spondylolisthesis that's caused by a fracture, I'll often follow them closely in the clinic to make sure it's not progressing. You know, it's a difficult one. We'll often let the symptoms guide if the symptoms are progressing. You often come in to get an x-ray to see if there's progression. The best thing I would say would help prevent progression would be to build your core strength. Limiting your activities is not necessarily a good thing to do. That often comes with immobility, and that's not an option in my mind. I really like you to continue your exercise strategies, your core muscle strengthening. That's the best way to prevent that from progression. So moving on, so options for stenosis. We've seen so many options over the years develop, and it depends again on the pathology. It depends if there's an instability or a spondylolisthesis. Oftentimes, if there's some level of instability, there's a stability device that is required. So many times when we see very severe forms of stenosis and we have to remove portions of the joints in order to relieve those nerves, it does create some level of instability, so we are required to put something back in order to stabilize. And the traditional approaches involve screws and rods in what's called an arthrodesis or a fusion. There's varying implants that have been developed as a result of trying to find something that's less invasive, and some are successful and some are not so successful. I'd say that the gold standard in situations where a fusion has to happen is the screws and rods with some form of an inner body technique. We can do that minimally invasively. There are techniques we'll describe a little further, whether it's taking out the disc from a front, from the side, or from the back. Those options can be done through a small tube, minimal soft tissue disruption. It's quite remarkable how we're really able to approach from every angle and to do so with less blood loss, less disability, and we're able to achieve the same fusion. We're able to correct malalignments and restore stability. These are some of the devices that haven't had the greatest success. The one, the X-Stop on the upper left, was one that was a simple device that recreates the sitting or sitting forward or bending forward position to open up just a little area for your nerves. That has fallen out of favor, has not been successful. So I say all this with, as the pendulum swings and we develop these new latest and greatest, we have to be careful, really look at what is tried and true, what the data shows works, and be careful with what's the latest and greatest. With that being said, we've had great success from something similar that it's called a Coflex device. This is an interlaminar stability that has stability that is drawn from a device that holds the segment into a little bit of distraction. We're able to directly take the pressure off the nerves, also still providing some stability. What really makes it a less invasive option is that we don't have to dissect the muscle groups very widely. When we get past the joints in a dissection, unfortunately, that does create a lot more damage to the muscle, pain, and more difficulty with recovering. This device is nice in that it provides a level of distraction that distracts the nerve tunnels. It opens up the area for the nerves and provides a level of stability while still allowing a flexibility. It's not a true fusion, but it does provide the benefit of a stability device while still with the dynamic properties of keeping the nerve tunnels open. So again, shorter hospital stays. We can do these generally outpatient or one night in the hospital and really achieve the same level of decompression and stability that we can through a typical fusion. So going on into cervical arthritis, so cervical diseases, we call it cervical radiculopathy or cervical myelopathy. Generally, when there's a nerve pressure, that's a cervical radiculopathy. It often is almost a sciatica of the neck where there's a nerve that's pressed. The distribution or dermatome, it does affect. It can vary depending on the level that there is either a disc herniation or a bone spur. The other type of pressure is spinal cord pressure. The presentation of spinal cord pressure or myelopathy is something that we're always a little more concerned about as surgeons, and that the symptoms associated with myelopathy can be a little bit more subtle, but the problem in the situation when there is spinal cord pressure, that unfortunately the spinal cord does not tolerate pressure very well. As we know from patients with spinal cord injuries, if there's a pressure enough to cause damage, unfortunately that damage on some level may be irreversible. The spinal cord pressure can create problems. The symptoms associated with spinal cord pressure include coordination loss, dexterity changes, problems with things like buttoning up buttons, turning keys, twisting jars. It can affect your balance. And these symptoms generally, they may progress for a short period of time and then level out and then get a little bit worse. The problem is that this stepwise deterioration can happen over years, and unless you address it, once you address it, it's very difficult to get back and restore that function. So it's very important if you're diagnosed with cervical stenosis and if it's severe and causing spinal cord pressure, it is something that there has to be some consideration. If there's progression and functional loss, options of surgery should be looked at. So the typical non-operative strategies really depend on the degree of pressure. If the spinal cord is very pressed and there's concern about a neurologic problem or a weakness that's developing, we may look at the surgical options a little sooner. But again, anti-inflammatory medications, physical therapy, epidural steroid injections is similar to the lumbar spine. The goal there is to reduce inflammation. It's not healing a problem. It's reducing some of the inflammation associated with pressure caused by a disc or bone spur. Fortunately, the surgical options in the neck, a lot of the anterior or front approaches are in themselves considered a less invasive option. The reason being is there really isn't any muscle that we're cutting in the neck. There's a very elegant plane and approach that we utilize through a natural plane of soft tissues, and we have a special retractor system that really allows us to gain wonderful access to where the pathology is, and we're able to remove it expeditiously, and the newer technologies we're able to restore range of motion. So the ACDF is considered the gold standard. It really is one of the best surgeries we have in spine. It really is less invasive. The problem is it's still a fusion. It still can create problems in a level that we don't fuse. So a level above or below, a rate of about 3% per year of deterioration of those levels. The other issue when we start to do multiple levels, the risk of those levels not healing, something called pseudarthrosis. Those are some of the key problems with the anterior cervical fusion. Posterior cervical fusion, sometimes we're required to consider that option because of the extensiveness and multiple levels involved. Unfortunately, it's probably the most complex of muscle layers we have to dissect through, and often if we do a screw and rod fixation construct, that's a more difficult surgery to recover from. In the past 15 years or so, longer than that even, the total disc arthroplasty has been developed and is now accepted as a standard of care for cervical pathologies where there's not a significant amount of arthritis in the joints. So patients who have more of a disc herniation pathology and pressure on the nerve or spinal cord, in order to preserve that range of motion and still be able to remove the pressure from that's causing the problem, we're able to do so and preserve the motion, thus preventing some of the issues with an adjacent level problem. So adjacent level disease, whatever disease process brought the individual to have a problem at the index level disc, it still can happen at the other, but any influence caused by a fusion would be negated by restoring the motion segment and being able to continue motion. One common misconception is that we're using the disc replacement to really maintain clinical motion. If I were to have two identical twins have a single level fusion and disc replacement, the range of motion would likely be, you wouldn't be able to tell the difference. It really is to prevent the problem from developing above or below. So of course in younger patients who have a lot longer to live, that's an important option to have. As the materials get a little bit better, we're seeing this evolution. The most common discs that I've used in the history of what I've used, the materials have changed. Really, the initial disc replacements, the bearing and the metal surface is very similar to a hip or knee replacement. The degrees of freedom and the motion mimics that of a natural disc. However, the material is very different. It's difficult to really reproduce the biomechanics of a natural disc. I think that there has been an evolution, and on the left is one of the disc replacements that's that's a little newer, that does tend to mimic the natural motion, and has seen some great success, and is one that I commonly use now. I bring up laminaplasty. It was pioneered in Japan. It's very common in the Asian populations to have something called the ossification of the posterior longitudinal ligament. It's an unfortunate disease that causes large bone spurs to really spread throughout the cervical spine, and it's not an approach that's safe to approach from an anterior or front approach. So having an option to really adequately decompress or remove the pressure from the spinal cord is important, and able to do so. This is a laminaplasty. We're able to preserve motion to really create essentially an open door. So you see on the top diagram on the left parts of the lamina where that stenosis is. If we're able to remove and open up and create more volume in patients, like I'd mentioned in the beginning, who are born with just less area for their spinal cord, we're able to essentially recreate a normal or wider spinal cord diameter. We still have to endure the problems with recovery and the soft tissue dissection, but motion preservation surgery that still achieves the decompressive qualities is very important. So again, I've gone over this, so there is less blood loss, quicker recovery, and it's a good option for these situations that involve multiple levels. Just a question, so for those with multi-level cervical disease, is it correct that surgical options are considered when all conservative measures do not lead successfully to ongoing pain management? So it really depends on the individual, it depends on the symptoms. I'd say as a general rule, back or neck surgery for purely back or neck pain is very questionable. We really have to look at the diagnosis, we have to look at the imaging, look at the degree of stenosis and pressure and the symptoms and correlate them. I'd say that in multi-level disease there are good options as long as what we're treating is appropriate and the expectations are realized. The hardest thing to promise always is 100% relief of neck pain. In fact, I'd say neck or back pain. I'd say anyone who promises you that probably isn't a good option to go with. We have to be realistic. I think the goals when we're trying to achieve in these surgeries is really reducing the pressure on the neurologic elements, really restoring function and improving quality of life. And we have to make sure we have the appropriate, we're addressing the appropriate generators of pain. So it is something is very much can be a good option, but it also may not be. It really depends on the individual. It's worth seeing and looking at what those options look like and really make sure that all of those conservative options have been ruled out, have been attempted. So with multi-level cervical disc disease who do not have lumbosacral pathology, is it correct that bladder and bowel dysfunction can develop similar to what is possible for those who have lumbar spinal pathology? Yes. So I sometimes see patients who come into the emergency room. In fact, I'm on call right now on a patient who had presented with bladder and bowel dysfunction who unfortunately, the initial MRI was normal of the lumbar. I said, we get an MRI scan of the thoracic and lumbar, and sure enough, it had a large thoracic lesion, and unfortunately, that presentation was strictly bladder and bowel. So it's always, it's in my mind, I'm looking for a potential cause. There's often associated signs, and they can be very subtle physical exam findings. However, it's something to be comprehensive and make sure that if one part of the spine looks completely normal, that we rule out being something higher. The spinal cord actually ends at the lower part of the thoracic spine around T12L1. So when we're dealing with the nerves can be pressed and have a lot more, they can tolerate more stenosis and pressure. Unlike the spinal cord level, a spinal cord level problem cannot tolerate that pressure. So the last topic is scoliosis. Scoliosis is generally thought of as a large surgery. It requires a major correction of a deformity. We see what we call coronal if we're looking from the front, the curvature from the front, or from the side. Probably the more common type we see in older degenerative populations is where we look from the side and they're having problems we call sagittal balance, having problems standing upright. That is more disabling than a scoliosis you see from a front or from a coronal imbalance, and it's often something that we have to address or look at, really even in the smallest surgeries, to be able to preserve that normal sagittal plane alignment. And we have these less invasive options. One of the most common ones I wanted to bring up is something called a direct lateral, where an incision is performed on the side. We can actually make an incision that is muscle sparing. We really are just spreading the muscles. We're able to, and this is just this shows kind of our approach. Really digitally, we're able to find the side of the spine through what's called the psoas muscle. The psoas muscle allows for flexion, for hip flexion. We're able to use a tubular retraction system and a neuromonitoring system that ensures we're not around the lumbar plexus or the nerves involved coming off the spine. And again, it's a quicker procedure, less blood loss. We're not cutting muscle. We're able to achieve very large corrections of deformities and corrections of scoliosis. And it really has revolutionized our field over the past 15 and 20 years. So it's an option we see here, just the intraoperative view, showing when we're able to actually address the disc and see, and there's a lot of our new navigation and and robotic systems that assist us in doing so. So we really are able to electrodiagnostically make sure we're not around your nerve roots or spinal cord, and be able to achieve through a very narrow corridor with minimal soft tissue disruption what in the past we had to make a large incision and a very morbid surgery. So this just goes through this system in particular. There's a lot of systems that have been developed because it's been such a great operation, but it just shows the disc space and the procedure itself and how we do and prepare the disc space and put a spacer in between to restore alignment and to stabilize a segment. So again, we're doing a great bigger surgery. It's a fusion surgery, but we're able to do so through a much smaller incision, minimal blood loss, and less hospital stay. So this is an example of a bigger surgery. This would traditionally be a very large, what we call osteotomy, and we're able to correct the deformity very nicely. This is more recent, a technology where we're able to, in a single position, achieve both a surgery from the side to correct and remove the disc and put a spacer in and keep the patient in one position and really do almost two surgeries in one. It really cuts the operative time, the anesthesia time, and it's kind of the new cutting edge that we've been performing at Hoag Orthopedic Institute. Again, I brought this topic up before. Be careful with the latest and greatest. We've kind of gone away from on the left, the lumbar disc replacements. I'm sure we'll find a way to preserve a motion segment in the future, but for now it just doesn't work very well. Kyphoplasty works in very selective patients. It's not as commonplace as it once was. So again, I think we have to take the new technologies with a grain of salt. What I presented today is something that is more tried and true and has become more standard of care, but we'll see a lot of these new interventions come in, and unfortunately, as quick as they came in, they'll go away because they just don't work very well. Well, thank you very much. I'll try to answer some questions here. How can physical therapy help with degenerative disc disease? And good question. So it's not so much that what you're doing is essentially building a scaffolding of muscle and stability around that degenerative disease. It's not necessarily the disc itself that's causing the pain. It's when there's movement associated with that degenerative disc disease that irritates those nerves that generally are already associated with the degenerative disc. Being able to build your muscle strength, being able to reduce some of the poor posture habits or alignment that puts more stress on that damaged disc. You're building up that core. It's two principles, core and posture. If you're able to maintain a good core, you're able to control your movements and limit the amount of poor posture positions that could put stress on a damaged disc. That's really what physical therapy is about. I think it's so important, and really is in any situation probably the most important factor that I do believe very strongly in. Can you correlate the spinal level of the damage with symptoms? Yes, very, very important point. So the dermatomes are probably the most common way we do that. So for instance, a quick way to remember, so if you have numbness, tingling, or pain in the thumb or index finger, it's the C6 distribution. C7 is the middle finger. C8 typically is the ring and small finger. And like I said, the S1 is more posterior outside or the back of the thigh. The lateral thigh tends to be L5, and the inside of the thigh tends to be L4. So very much also weakness. So weakness in most common presenting level involved is between L4 and 5, and that typically will affect the strength of your dorsiflexion or extending your ankle. So one common thing I tell patients to do at home to test that strength is just to try walking on your heels. If you're having problems walking on your heels and your foot slapping on the ground, or your loved one hears you walking down the hall with your foot slapping, that's an indication to me. I think L4, L5. So yes, that's a very good question. That's part of our physical exam and what's so important. Okay, good. Is there any other questions? I think we're about out of time. I appreciate you sitting through, and certainly happy to see you in the office if you have more questions. Thank you.